What if I told you this patient was treated with Ponatinib, everyone? What do we think about that?
Well, if I have no mutations at this stage,
And that was the finding.
I would consider Dasatinib for this man. But if I have any mutation or any sequencing showing any aggressive features, I would have gone to Ponatinib. I'm concerned about the hypertension still, and I'll be more on the safe side to go for Dasatinib.
It's really interesting. Again, you get to really be a true internal medicine physician again with some of these patients, right? They present with these comorbid illnesses. You're looking at multiple organs that you're helping to manage in this 62-year-old. You're starting on agents that can impact all of those things. And really, one of the things we do is we have to sort of begin to minimize their risks long term, because our expectation, our hope is that these patients will be on these drugs for not just months, but years and maybe decades. And so to maximize and improve their cardiovascular risks, their risk of diabetes, their risk related to hypertension, those all have to be really managed in patients like this. So I think that came along with the patient when they walked in the door with this history, that you're going to have to be worried about lots of other organs, not just the bone marrow.
So a question to Mike, you want to go for Ponatinib, what dose you would choose for this man?
Let me just temper that by saying that I'm not sure I would have gone with Ponatinib, but I think someone might have considered it. And if we think about what dose, so I think that's an open question as well. I think we still are looking at data emerging to tell us what the right starting dose of Ponatinib could be, ranging from 15 to 45 milligrams. Personally, I would have used 30 milligrams as an intermediate step, knowing that there may be data that that's a sufficient dose. Perhaps this clinician who might have chose Ponatinib, and I think, not to say it was a bad choice, might have been looking at the PACE trial, where there is data for patients with only a single TKI who actually did the best. But I think the devil's in the details there, that those are really patients with a Ponatinib exposure generally that had a T315I mutation. So that probably would have been the right setting for this choice. Although the earlier Ponatinib is used, the better the response is with regards to major and complete and durable response. And the long-term outcomes from PACE are quite good, but we've all raised very important issues. Number one, cardiovascular assessment, hypertension being a common toxicity and could very well likely get worse. I would have sort of had a look at this patient's cardiovascular profile probably right from the beginning, given their age and their comorbidity status and higher risk CML, and now knowing we might have used another therapy. And what dose to use if we were going to use it. And I think we probably might agree that this is maybe a place where Ponatinib is used as a third-line therapy. So.
And I think we all have opportunity to discuss the dosing in further cases. But I would agree with you. I think sometimes for our patients with CML, the most important thing we might do that day is check their blood pressure, monitor their lipids, because most of our patients are going to do quite well. With that in mind, I think case 2 will kind of demonstrate the relevance of mutational testing and how that might guide our treatment decisions.